those are my disclosures. So first of all, thanks to the COA, Ortho Evidence, and the CAS for inviting me to talk about this. It's an area of my passion. I would say 98% of all total hips that I perform are anterior now. I have almost completely made that transition. Just like Dr. Lisa Howard said, nothing's black and white. There's lots of controversy in the literature. There's always benefits and downsides. You got to kind of decide on your own. Now, I was given the opportunity to talk kind of 8 minutes in total on anterior approach and the transition, which I think is not really possible. So I'm going to focus more on the anterior approach, and hopefully in the Q&A I can talk about the transition. But really, once you see the results, it becomes an addiction. And I had the unique opportunity and privilege to work with Dr. Jamie Howard. He was one of my fellowship preceptors, and if you don't recognize this is Dr. Howard. This is what he looks like when he's finished his anterior hips, and he's all excited about it. Jumping into this introduction, medicine is practice today is virtually unrecognizable from the turn of the century. Things are going to continue to change, and the question is, how do you make a really good operation even better? And that's what we're talking about today. I'm going to talk about the anterior approach. I'm not going to jump into this too much because Dr. Howard already spoke about it, but the anterior approach is the internervous and intramuscular approach to the hip and between tensor fascia sartorius superficially and rectus and tensor fascia deep. Now, I believe the true value of the anterior approach is not necessarily the obturator internus or their conjoint of the piriformis, but I really believe it's the preservation of both the posterior capsule and the IT band, which is where you see the real benefits. Just like Dr. Howard said, this is not new. Since the 1940s is when this has been started. It's just popularized now because of better instrumentations and teaching program. It can be performed both with a table and without a table. You don't need to use new implants. That's a common thought that people have. Now, the biggest issue when you look at the literature about the anterior approach to assess the value is the inconsistency of the approach. Now, what do I mean by that? People will try to compare cemented and uncemented cups and stems, whether you use x-rays, whether you don't use fluoroscopy, whether you use a table, whether you don't use a table. Then they try to compare, in the ideal circumstance, you would compare a 32 or 36 femoral heads with the 32 or 36 femoral heads of a different approach, but that's not really what the literature has. You have to dive into the actual studies to realize sometimes they're comparing 32 and 36 anterior approach heads with 40 millimeters of dual mobility heads on the posterior approach. So you really got to know what you're trying to compare when you read the literature, and I really encourage you to look at the papers when you're assessing it. What I'm going to try to advocate for here is really using the anterior approach with fluoroscopic assessment, and I'll jump into that as to why. Now, there's lots of benefits on my personal biased opinion, if you want to put it that way, because I really do believe in the anterior approach. And there's lots of benefits, and there are some downsides, and I do acknowledge that. And because of the constraint of time, I'm going to focus pretty much on three areas: pain, increased function stability, and radiographic assistance. And some of that, Dr. Lisa Howard's already kind of alluded to as well. But in terms of pain, it's extremely important because it's one of the most feared postoperative issues for patients, and it can be managed with any approach if you use multimodal analgesia, preoperative counseling, etc. But really, in terms of pain, if you really want to understand it, you don't only need to understand what the subjective patient reporting is, but you also need to objectively try to quantify exactly how much narcotics they're using to achieve that comfort. And in the combination of those two, you really get to understand how the approach affects differences in terms of patients. Now, less pain means a more comfortable patient, quicker recovery, less nausea, better patient experience. Thanks to Ortho Evidence for providing some of these slides here, but this ACE report showed lower pain with the direct anterior approach versus the lateral approach. And what this paper looked at was 70 patients, all using 32 millimeter femoral heads, same implants, same multimodal analgesia. They measured a seromyoglobin to look at markers of muscle damage and pain scores. And what they basically found, I'm going to try to summarize this as quick as I can, is the anterior approach was associated with a significantly smaller increase in myoglobin levels, in other words, less tissue disruption, lower pain in the first postoperative day, and lower perioperative morphine consumption when compared to the direct lateral approach. This is a study that we did, a retrospective matched cohort study with 120 anterior approach with 240 posterior and 240 lateral approach, and looking at specifically narcotic consumption. We showed that there was a significant decrease in total narcotic consumption during the acute inpatient hospital stay. But when you look at total narcotic consumption, assuming that we place our threshold for clinically meaningful difference of reduction in narcotic consumption at 30%, it was over 400% reduction, which was quite significant. Now, jumping into my second area, increased early function and stability. Ultimately, as Dr. Lisa Howard said, all total hips eventually do well, but really the demands of patients are changing, and we need to acknowledge that early functional recovery and improved stability are strongly desired. And that trails not only from post-op day one, but continues on afterwards, whether you want to call that a patient bias, a surgeon bias, or a bias of having less pain initially and continuing that positive outlook. It depends on how you want to see it. And the value of soft tissues are extremely important. For example, the IT band is an extremely important internal rotator, hip abductor, and holds the pelvis level. And it's logical, if you preserve the IT band, you'll get better results. Now, unfortunately, there's no real good studies to assess specifically the IT band, but we do know, for example, the posterior capsule. If you repair the posterior capsule, there's many studies and systematic reviews and meta-analyses showing that if you repair it, it reduces the risk of dislocation of the posterior approach. But it's interesting when you see this JS article in 2019 showing that even the posterior approach, that those with capsule repair, just under 50% of those capsule repairs eventually fail when looking at it through an MRI, which increases the risk of dislocation through the posterior approach. Looking at specifically the anterior approach, this is a 2021 article that we looked at just under 800 posterior approach patients with 690 anterior approach patients. No dual mobility heads were used here. I tried to compare two even groups, and the risk of postoperative dislocation was lower in the anterior approach and even in those with higher risk patients. And a study in March of 2021 showed that when you look at that higher risk patients, for example, those who have displaced femoral neck fractures, anterior approach still had a lower risk of dislocating. In terms of early functional recovery, this ACE report basically looked at about 128 patients. They excluded the first 100 anterior approach cases to remove this concept of the learning curve. And what they basically looked at, they demonstrated significantly shorter length of stay, lower pain scores over the first 3 days after surgery, and higher functional scores in the first 3 months after surgery. They also identified longer operative time and greater blood loss. Now, jumping into this, I was curious exactly how much operative time. It was 18 minutes longer to do the actual operation and 42 mils of blood loss. Now, 18 minutes is about right for what my experience was personally when I first started it. Now it's completely the same. What that meant though was we could do the same number of cases in a day. It just means you end the actual end time of your day versus finishing early. Length of stay, I'm not going to jump into this because this is a 30-minute talk on its own, which I'm always happy to do, but all I have to say is anterior approach is just one way for reducing length of stay in day surgery, but there's many other ways that I'm going to acknowledge the fact that protocol driven, better nausea, and et cetera, are different ways to achieve it as well. But anterior approach, just to put it out there, is one way to achieve success in terms of day surgery, total hip replacements. Now, in terms of the third area, radiographic assistance, I think anterior approach is a very easy way to get intraoperative assessment with fluoroscopic assistance. And what that means is you can get accurate leg length offset, femoral stem size, acetabular cup placement. You can view in case you have intraoperative complications like fractures, you can deal with it if you see it at the time versus having to find it afterwards. And then you can add on other things like adjuncts, for example, navigation or printout overlays to make the hip replacement even more accurate. I honestly believe gone should be the day that we have this X-ray as a post-operative image. Say to yourself, well, this patient will do just fine. But when you actually write out do the measurements of leg length discrepancies and the cup abduction angle, I don't think this is acceptable anymore. And simply by having X-rays during an anterior approach case, you can easily make those adjustments while you're doing it. And so taking it out of Varus, for example, and so you'd have outcomes and X-rays that you're extremely happy with by the time you're done the case. So when you leave the operating room, you know exactly where those implants are, how they are, what the leg length and offset, and you've created the best outcome you can, and understanding some of these things need to be altered. Now, this is an interesting ACE report that was out there. It looked at similar radiographic outcomes in total hip arthroplasty using direct lateral and a direct anterior approach. Sorry, lateral approach and a direct anterior approach. They used 164 patients. They both had cemented acetabular components and cemented femoral components. And basically what the summary was, the two approaches were similar in their ability to obtain adequate component positioning, mantle thickness, offset, leg length discrepancy, with the exception of acetabular inclination, which was more frequently considered adequate in the direct lateral group. Now, this was surprising to me because in my hands, when I have x-rays and fluoroscopy during the case, I don't understand it. So I jumped into the actual paper, downloaded the paper, read it, and sure enough, they didn't use fluoroscopy, or any x-ray assessment was used during the anterior approach, which I think is a huge benefit of the anterior approach. When you actually look at the literature and look at intraoperative fluoroscopy, when you can use that during the anterior approach, sure enough, this paper published in 2020 with 100 posterior approach patients and 100 anterior approach patients, they had more accurate anatomic restoration of leg length, femoral offset, total offset, ideal cup abduction, and cup anteversion. In fact, it was even more interesting to see that there was a tendency of increasing offset and leg length in the posterior approach. And in my experience, and also in this paper that they had also talked about, those are likely due to the fact they're trying to increase more stability using the posterior approach by doing those things. This is an ortho evidence original paper looking at surgical approaches. It was a network meta-analysis. They basically looked at the effectiveness of anterior, posterior, or the lateral approach groups. This is a very, very convoluted and busy slide, but basically what happens here is they took 21 randomized control trials looking at the Harris Hip score, 13 randomized control trials at visual analog scale, and tried to compare. And what they basically came out with was the anterior approach was superior in terms of the Harris Hip score, both 1 month to 3 months compared to the posterior approach, and 3 months and 12 months to the lateral approach. And when you're looking at the VAS, it was up to 1 week more beneficial for the anterior versus posterior group. Now, people say, well, what's 1 week mean? But I really believe that that early change and early less pain function really translates throughout the whole experience of a patient. So in conclusion, in this paper, the anterior approach demonstrated superiority over the lateral and posterior approach groups. So in summary, when assessing the literature, you got to really make sure you're comparing the groups that you actually want to perform you as a surgeon and give to your patients. I do believe that the anterior approach does have benefits, and the real key here is to avoid downsides, specifically the learning curve. And just to touch upon that before I end, I do honestly believe that the learning curve now is a lot different than that published in the literature, and that in terms of in real life. And the reason for that is the huge supports that you can now get to learn and bring the anterior approach into your practice in terms of courses, cadaver courses, surgeon to surgeon visits, reverse surgeon to surgeon visits, local supports. There's so much out there now for surgeons to be able to safely bring that into their practice if they feel that's appropriate. Now, I only focus on pain, functional instability, and radiographic assistance, but I do believe there's more benefits of just this, but because of the time constraints, I limited to that. And thank you.